Hello everyone. So today we will continue this series of lecture on ECG. So we have already discussed that in interpretation of an ECG we'll look for these 11 things, that is rate, rhythm, axis, P wave, PR interval, QRS complex, ST segment, QT interval, T wave, U wave and progression of R wave in chest leads. Okay. So till now we have discussed about rate and rhythm. Now we'll continue with axis. Okay. So for axis, we'll need only limb leads, as axis has to be determined in xy plane only. As we have already discussed that we have 6 limb leads, lead 1, 2, 3, which are bipolar, lead AVL, lead AVF, lead AVR, which are unipolar. Okay. So we will determine the axis with these 3 leads only. This is our lead 1 with negative electrode on right upper limb and a positive electrode on left upper limb. This is our lead 2, lead 3 with a negative electrode on left upper limb and a positive electrode on left lower limb. And this is our lead 2. The negative electrode on right upper limb and a positive electrode on left lower limb. So these are lead 1, 2 and 3. And they form an equilateral triangle with 60-degree angle at each point. Okay. Then a lead perpendicular to lead 1 facing downwards is lead AVF. Lead perpendicular to lead 3 facing towards right upper limb is lead AVR. And a lead perpendicular to lead 2 facing left upper limb is lead AVL. Now, if we draw it in a symmetrical way, suppose this is a circle, this is our lead 1, this is lead 2, and this is lead 3. Clear? And we have 60-degree angle here and a 60-degree angle. Lead 1, 2, 3. A lead perpendicular to lead 1 is lead AVF. A lead perpendicular to lead 2 is lead AVL. And a lead perpendicular to lead 3 is lead AVR. Clear? Okay. So the normal axis is minus 30 to plus 100. But for making the calculation easy, we take it as minus 30 to plus 90. So the normal axis is between lead AVL up to lead AVF. This is our normal axis. Okay. Now what is right axis? This is right axis from lead AVF up to plus 180 degree. Then what is left axis? This is from minus 30 to minus 90 is left axis. This area is left axis. And this area from minus 90 to 180 is extreme axis or northwest axis. Okay. So for determining the axis, we need 2 perpendicular leads. So for all practical purposes, we are using lead 1 and AVF. Okay. This is lead 1 and this is lead AVF. Okay. Suppose the QRS complex in lead 1 is positive and the QRS complex in lead AVF is also positive. Okay, so since the QRS in lead 1 is positive, so axis would be somewhere in this hemisphere. Okay, And the QRS in lead AVF is also positive. So access would be somewhere in this hemisphere. Okay. So this is the overlapped area, and axis is 0 to plus 90. That is normal axis. Similarly, if lead 1 has negative QRS and lead AVF has a positive QRS. Okay. So since lead 1 has a negative QRS, axis would be somewhere in this hemisphere. And lead AVF has a positive QRS, so axis would be somewhere in this hemisphere. That's why the axis would be in this overlapped area, that is plus 90 to 180, which is right axis deviation. Now we'll take the third scenario. In this third scenario, lead 1 is showing a negative QRS and lead AVF is also showing a negative QRS. Okay. Since lead 1 is showing a negative QRS, the axis would be in this hemisphere. Okay. And since lead AVF is also showing a negative QRS, so axis would be in this hemisphere. Overlap region is this, minus 90 to 180, which corresponds to northwest axis, which is also known as extreme axis. Okay. Now we will take the last scenario. In this scenario, we have to look on lead 1 and AVF as well as lead 2. Okay. Suppose lead 1 has a positive QRS and lead AVF has a negative QRS. Since lead 1 is having a positive QRS, axis would be in this hemisphere. While lead AVF is having a negative QRS, so axis would be in this hemisphere. So overlapped region is this. So axis would now be from 0 to minus 90. Okay. But as we know that 0 to minus 30 corresponds to normal axis, while from minus 30 to minus 90 there is left axis. Okay. So in this scenario we have to look at lead 2 also. Okay. Suppose lead 2 is positive. Okay. Now this is lead 2. Okay. So since if lead 2 is positive, axis would be in this hemisphere. Okay. So this is the overlapped region. That's why the axis would be from 0 to minus 30, which is a normal axis. Suppose if lead 2 is negative, then axis would be in this hemisphere, and that would be the overlapped region. So axis would be from minus 30 to minus 90, which corresponds to left axis deviation. Okay. So for all the axes, we have to look at lead 1 and AVF. But in this special circumstance, we have to look at lead 2 as well. Clear? Now, how to say that a QRS is positive or negative in a particular lead? Okay. Suppose this is a QRS in lead 1. Okay. So we can easily say that this is a positive QRS. But suppose if QRS is like this, how can we say that it is a positive QRS or a negative QRS? So we have to calculate the Q, R, and S segment. If suppose Q is 3, R is 5, S is 3. So the QRS segment would be R minus S minus Q, 5 minus 3 minus 3 minus 1. So in this case, the QRS effectively is negative. Okay. So this is how we'll calculate whether the QRS is a positive or a negative complex. Now, what are the causes of axis deviation? Okay. So right axis deviation, left axis deviation, and northwest axis deviation. The causes of right axis deviation are RVH, that is right ventricular hypertrophy. Then we have left posterior fascicular block. And in infants up to 1 year, right axis can normally be seen. The causes of left axis deviation are LVH, left anterior hemiblock, which is the most common cause of left axis deviation, left bundle branch block. Okay. The thing to be noticed is that in RBBB, right axis deviation is generally not found until unless RBBB is because of RVH. Clear? For northwest axis deviation, the causes are extreme RVH leading to northwest axis deviation. Then we can have ventricular tachycardia or ectopic arising from apex of the heart. Okay. So this is an ECG, and we have to find out what is the axis in this ECG. Okay. So as we can see that lead 1 is showing a positive QRS here. Lead AVF is also showing a positive QRS here. And as we have already discussed, since lead 1 is showing a positive QRS, axis would be in this hemisphere. Lead AVF is showing a positive QRS, axis would be in this hemisphere. So axis would be normal from 0 to plus 90. Okay. Now, since we have already discussed how to find out the rate and rhythm of an ECG, so from this ECG we can also calculate the rate. 1, 2, 3, 4. Almost 4 big squares are there. So heart rate is 300 by 4, which is equals to 75. As we can see that RR interval is same in all the complexes. So rhythm here is regular. Okay. Now let us look at this ECG. What is the axis in this ECG? Lead 1 is showing a negative QRS. Lead AVF is showing a positive QRS. Since lead 1 is showing a negative QRS, axis would be in this hemisphere. Lead AVF is showing a positive QRS, axis would be in this hemisphere. Overlapped region is this, so axis would be from plus 90 to 180, which is equals to right axis deviation. Again, the heart rate here is almost 3 big squares, it is 300 by 3, and rhythm is regular. Okay. Again, let us look at this ECG. Lead 1 is showing a positive QRS. Lead AVF is showing a negative QRS. Okay. Since lead 1 is showing a positive QRS, axis would be in this hemisphere. Lead AVF is showing a negative QRS, so axis would be in this hemisphere. Sorry. Lead AVF is showing a negative QRS, so axis would be in this hemisphere. Overlapped region is this. So axis would be from 0 to minus 90, which can be normal or left axis deviation, depending upon whether axis is between 0 to minus 30 or minus 30 to minus 90. For this, we have to look at lead 2. Lead 2 is negative. Since lead 2 is negative, axis would be in this hemisphere. Overlap region is this, that is from minus 30 to minus 90. So this ECG is showing left axis deviation. Clear? So till now we have discussed that we have to look at rate in an ECG, then rhythm, then axis. Now we'll look at waves, different waves and intervals in an ECG. So first thing to look in this is P wave. Okay. As we all know that P wave is because of atrial depolarization. And the best leads to look for P wave is lead 1, lead 2 and lead V1. Okay. So we will look for lead 2 and V1 for looking at P wave. Okay. The normal P wave in lead 2 is like this. Less than 2.5 small squares width and less than 2.5 small squares height. The initial half is because of RA depolarization. The later half is because of LA depolarization. Okay. Similarly, in lead V1, this is how a normal P wave would look like. So the normal P wave in lead V1 is biphasic. Upward deflection is because of RA depolarization. Downward deflection is because of LA depolarization. And both of upward and downward depolarization is less than 1 mm. Clear? Now, what are the pathologies in P wave? In lead 2, suppose if P wave is tall, okay, that is, it is more than 2.5 mm height, but the width is normal, that is less than 2.5 mm. It represents RA enlargement. Okay? And the most common cause of RA enlargement is pulmonary hypertension, so it is also known as P pulmonale. Okay? Similarly, if the width of the P wave is more than 2.5 mm, but height is normal, that is less than 2.5 mm. So it represents LA enlargement because the later half is because of LA depolarization. Clear? And the most common cause of LA enlargement is mitral valve diseases. So it is also known as P mitral. Clear? Now in lead V1, as we know that normal P wave in lead V1 is like this biphasic with both upward and downward deflection less than 1 mm. So suppose if upward deflection is more than 1 mm, it represents RA enlargement. If downward deflection is more than 1 mm, it represents LA enlargement. Clear? Now the fifth thing to look for in an ECG is PR interval. First of all, what is a PR interval? PR interval is P wave plus PR segment. P wave is because of atrial depolarization. PR segment is because of AV nodal delay. Okay. Now the normal PR interval is equals to 0.12 to 0.20 seconds. Or we can say it as 3 to 5 small squares. The PR interval is more than 5 small squares. We call it as increased PR interval. If it is less than 3 small squares, then we call it as decreased or shortened PR interval. What are the causes of increased PR interval and shortened PR interval? So increased PR interval will be there in AV blocks. We have three types of AV blocks: first degree, second degree, third degree. We'll discuss about them in subsequent classes. The causes of shortened PR. The causes of shortened PR is WPW syndrome. Any accessory pathway which is bypassing the AV node. LGL syndrome. And then we have long RP tachycardias, like atypical AVNRT, PJRT. Now this is an ECG showing shortened PR interval along with this delta wave. Okay, so this is an ECG of WPW syndrome. In WPW syndrome, we have an accessory pathway connecting the atria to the ventricles and bypassing the AV node. Okay. So we have this formation of delta wave because of the conduction through accessory pathway, as accessory pathway is conducting directly into the ventricles without conducting through bundle branches and Purkinje fibers. And as we know that ventricular musculature conducts at a slower rate. So there will be this delta wave followed by a normal QRS. Now QRS complex. So QRS complex represents ventricular depolarization. The normal width of QRS complex is 0.10 to 0.12 seconds. If it is more than 0.12 seconds, then we call it as broad QRS. There are multiple causes of broad QRS, but the basic pathophysiology is that the conduction is not occurring through normal Purkinje fibers or bundle branches, but it is conducted through ventricular musculature. Okay. Another thing to look in QRS complex is their amplitude. Because whenever there is any hypertrophy in any segment of the heart, like left ventricular hypertrophy or right ventricular hypertrophy, the amplitude changes. So for QRS, we have to look at amplitude and the width. With amplitude, we'll come to know about hypertrophy like LVH and RVH. With width, we'll come to know about broad QRS or normal and narrow QRS. Causes of broad QRS are bundle branch blocks, ventricular tachycardias, WPWs, and ventricular ectopics. Okay. Now LVH. So suppose this is in heart. If left ventricle hypertrophies, if lead V1, V2, V3. So if left ventricular hypertrophy is the major depolarization of the ventricles shifted from here to somewhere here. Okay. So vector has a direction and amplitude. So the amplitude of this vector also increases, the direction of this vector also changes. Okay. So in V1, we normally have this RS wave. And in V6, we normally have this QR wave. Now since the vector is moving more towards V6 and more away from V1, so in LVH, the RS complex in V1 would more dip down, and in V6 the QR complex would be having a large R wave. Okay. Also, lead AVL is somewhere around here. Now the QRS vector is moving more towards AVL, so AVL will also show a large R wave. So the criteria for LVH is we generally use two criteria. One is Sokolov Leon criteria, and another one is Cornell's criteria. In Sokolov-Leon criteria, we have two components. One is S in V1 plus R in V5 or V6 should be more than 35 mm. Another component is R in AVL should be more than 11 mm. And in Cornell's criteria, we have R in AVL plus S in V3 should be more than 28 mm in males and more than 20 mm in females. Okay. We have also heard about RVH with strain or LVH with strain. So what is strain? So suppose LV hypertrophy is here. Okay. These are V5, V6, 1 AVL. These are my lateral leads. Okay. These leads will show T-wave inversions. If T-wave inversions will be there in these leads, then we will say that it is LVH with strain. Now, why there is T-wave inversions in these leads? The direction of normal depolarization is endocardium to epicardium. Okay. The direction of repolarization is epicardium to endocardium. Now, here, when LV hypertrophies, the direction of depolarization is this, like this, going from endo to epi. In normal myocardium, repolarization will begin from epi and then go towards endocardium. But when there is hypertrophy of the LV, the depolarization cannot fully go till the epicardium and repolarization has to start. So the beginning of repolarization is now from endo to epi. So the direction of repolarization reverses in lateral leads. So in LVH, the lateral leads are 1 AVL, V5 and V6 and they will show T-wave inversions. Similarly in RVH, leads V1, V2 which are on the right side will show T-wave inversions. Okay. Now, these T-wave inversions will not be there in volume overload type of LVH. Okay. So we have two types of LVH. One is volume overload, one is pressure. Pressure overload LVH is also known as concentric LVH. Volume overload LVH is also known as eccentric LVH. Okay. So the criteria, that is Sokolov-Leon and Cornell's, will be applied to both, but in pressure overload there will be strain pattern, which is not seen in volume overload as the width of the muscle doesn't increase in volume overload. Okay. Also in volume overload, we'll be having deep T waves in lead V5 and V6. And the cause of these deep T waves is Brody effect, which we will discuss later. Okay. Now let us come to RVH. Suppose now right side of the heart hypertrophies. We have lead V1 and V2 here. Okay. So the criteria for RVH is R in lead A V1 should be more than equals to 7 mm, or R to S ratio in lead V1 or V2 should be more than 1. Clear? Also, we will be seeing the strain pattern, that is T wave inversions in lead V1 and okay. Now, what are the causes of LVH and RVH? The causes of LVH are the most common cause is hypertension. Then LVH can be seen in aortic stenosis. Then LVH can also be seen in mitral regurgitation. LVH can also be seen in aortic regurgitation. The causes of RVH are pulmonary hypertension, mitral stenosis, AST. Now let us come to the bundle branch blocks. As we already discussed that the ECG in bundle branch block would be having broad QRS. That is QRS would be more than 0.12 seconds or more than 3 small squares. Okay. As we have already discussed that the depolarization starts from SA node over till AV node, from AV node to bundle office. Then we have left bundle branch, which divides into left anterior and posterior vesicles, right bundle branch. Okay. The first part to get depolarized is mid part of interventricular septum because of left bundle branch. Okay. So in lead V1, suppose we are looking from lead V1 and there is right bundle branch block. Okay. And since right bundle branch doesn't conduct, the right ventricle has to get depolarized through the musculature only, and it will get depolarized late. Okay. So suppose we are drawing a QRS complex here in respect of lead V1. So the first part to get depolarized is interventricular septum. The direction is towards the lead V1. So we'll be having a positive R wave here because of interventricular septum depolarization. Then the second part to get depolarized is left ventricle, and it get depolarized through the Purkinje fibers. So we will be having a negative wave due to the depolarization of the LV as it is going away from lead V1. And the last part to get depolarized is RV, and it is getting depolarized through the musculature. So it will be taking more time and the vector would be large. So we'll be having a positive R dash V1. So we'll be having R as R dash pattern in lead V1 in RV. Clear? Now we will draw the vector in respect of lead V6. This is lead V6. Again, right bundle branch is not working. So in lead V6, the first wave is a negative wave because of the septal depolarization. We'll be having a negative wave here. Second wave is a positive wave because of this LV depolarization. And the third wave is a negative wave because of RV depolarization. So we'll be having this QS pattern in lead V6. And lead V1, as we have already discussed, we will be having this R as R dash pattern. This is also remembered as M pattern and W pattern. Again here, since RV is getting depolarized through muscles, okay, and bundle branch and Purkinje fibers are not working here, again the depolarization will be slowed. The direction of repolarization will get reversed in the right sided leads. So we'll be having V1, V2 with T wave inversions. Now let us look at this ECG. In this ECG, you can see that in lead V1, the QRS is broad. Clear? Also, we have this RSR dash pattern. While in lead V6, we'll be having this QRS pattern. So this is an ECG of right frontal branch. Also, we can see that axis is normal here, as I have already told you, that in RBVP, until unless associated with RVH, axis will be normal. Okay. Again, you can see here that this is RSR dash pattern, and this is QS pattern can be there or QRS pattern can be there. Also, you can also notice here that T wave is inverted here. Now let us discuss about LBBB. Let us look in respect of lead V1 first. Okay. As we have already discussed that the first part to get depolarized is mid part of interventricular septum. But since left bundle branch is not functioning, so the interventricular septum will get depolarized because of right bundle branch. Okay, so the direction would be like this. Then the second part to get depolarized is right ventricle through the Purkinje fibers, and the last part to get depolarized is left ventricle, which is occurring through muscles. So in respect of lead V1, we'll be having a negative wave first because of interventricular depolarization. Then we'll be having a positive wave because of RV depolarization, and we'll be having a large negative wave because of LV depolarization, which is occurring through the muscle. So we'll be having this QS pattern and lead V1. Now let us look at lead V6. Okay. In lead V6, the first wave would be a positive wave because of septal depolarization. Then a second wave would be a negative wave because of RV depolarization, and a large positive wave because of LV depolarization through the muscle. So we'll be having this RSR dash pattern here. While in lead V1, we have discussed, we have this QS pattern. This can also be remembered as W pattern or V pattern in lead V1 and M pattern in lead V6. Again, here the direction of repolarization will reverse in left-sided, left lateral leads. So we will be having V5, V6 with T-wave inversions. As we can see here that we have this RSR dash pattern in V6 and V pattern or RS pattern or QS pattern. So these are some alterations that we can have QS pattern, we can have RS pattern, okay? Or V pattern and M pattern here with T-wave inversions in lateral leads. Clear? So thank you very much, and we'll discuss the further topics in subsequent classes.